gas and alveolar gas. So the carbon dioxide keeps increasing. And the third phase, it's a steady expiration phase where only the alveolar gas is coming out, which is full of carbon dioxide. And at the end of the expiration, that is end tidal carbon dioxide, that is EtCO2. That is what we measure. And this is the typical waveform in a controlled ventilation. Now, what are the uses of this capnography? If you see this, it measures end tidal CO2, and as I told, like it measures. The scientists are again Bethune and Brechen. This was a question way back asked in 2016. And normal EtCO2 is 35 to 45 mmHg. And this is an indicator of ventilation, metabolism, and pulmonary blood flow. Okay, this EtCO2 can be measured by mainstream or side stream, not an important thing. And as I said, phase 0 is basically inspiration, and phase 1 is an anatomical dead space gas. Phase 2 is a mixture of anatomical dead space gas plus alveolar gas. Phase 3 is a steady alveolar gas. So this is just for your understanding. Now coming to what is the most important use of this. EtCO2 is the surest sign of correct intubation, in addition to other things. Like there are other ways how you can identify the intubation, but the surest and confirmative sign of correct intubation is end tidal capnography. And to monitor and diagnose malignant hyperthermia, where you see rapid increase in EtCO2. And to diagnose pulmonary embolism, where you see rapid decrease in EtCO2. And to detect any obstruction in the endotracheal tube or airway, which gives the characteristic sharp fin appearance. We'll discuss about each waveforms. Sharp fin appearance. Okay, this is what you have to remember. And then coming to capnography waveforms, the one which you see the inverted, the square-shaped waveforms is controlled ventilation. This is a normal and controlled ventilation. This is normal, which you see in controlled ventilation. What you see here as a square forms. And if you see the same thing here, this inverted U-shaped forms. This is also normal, but in spontaneous ventilation. Spontaneous ventilation. And if you see here, this is the characteristic shark fin appearance. This is due to the obstruction. It looks like this. Here what happens is the phase 2 and phase 3. This is how the normal waveform looks like. So this phase 2 and phase 3 gets merged up. So due to the obstruction of the airway, mainly seen in, this is due to obstruction of airway. Either it might be kinking or endotracheal tube obstruction, or in obstructive lung diseases. Like COPD and asthma. Okay, then coming to this waveform, no need to go into the complex details of this. If you see these oscillations, then jump and answer. This is a cardiogenic oscillation seen mainly in few children and with those who have thin chest wall. This oscillations, cardiogenic oscillations. And is seen in few children and in those with thin chest wall. Then again, this is a very important capnographic waveform where you see this, a dip. This is a controlled ventilation, basically. Controlled ventilation, this is why you have a inverted square-shaped waveforms, and you see the dip here. This is an indicator, this is called as a curare cleft or curare notch. This indicates a spontaneous breath in a controlled ventilation. under controlled ventilation. That means the controlled ventilation, you had given muscle relaxant and you are controlling, suddenly the patient starts breathing. So that is a spontaneous breaths in controlled ventilation. Spontaneous breaths in controlled ventilation. So now the question is, if you see this curare cleft or curare notch, you may get a question. So curare cleft or curare notch, so the patient is being operated for lap appendicectomy, and in the middle of the surgery, you see a waveform like this. Suppose you see this in the middle of the surgery, what do you do? When you see this in the middle of the surgery, you have to continue the surgery because you have to give a muscle relaxant. So you have to administer muscle relaxant so that again the patient goes into a controlled ventilation. So if it is in the middle of the surgery, you have to administer muscle relaxant. Muscle relaxant. At the same time, if the similar thing occurs after the surgery or at the end of the surgery, that means the patient, like whatever the muscle relaxant which you are given, the effect is about to complete, and the patient is start having spontaneous breaths. That is very much required for us. We want to bring the patient out from anesthesia and muscle relaxation. So in this condition, you have to administer reversal agent. Administer reversal agent. Administer reversal agent. Administer reversal agent. This is very, very, very important. Curare cleft or curare notch. What happens if it is in the middle of the surgery or after the surgery or end of the surgery? Okay, then this is very important. This is a flat line capnograph. Suddenly the waveform looks like this. Suddenly with the waveform, whatever is like, it becomes like this. This is called as flat line capnogram, where suddenly it becomes zero. Flat line capnograph, where it is seen in conditions of cardiac arrest. It's seen in conditions of cardiac arrest, in conditions of esophageal intubation, circuit disconnection, and even in conditions of accidental extubation. Accidental extubation. Accidental extubation. Then see this waveform where you see a slow increase in EtCO2. If you see a waveform like this where you see a slow increase in EtCO2, the slow increase in EtCO2 is characteristic of hypoventilation. Hypoventilation. Exactly opposite this, a slow decrease. Slow decrease in EtCO2 is seen in conditions of hyperventilation. Hyperventilation. Similarly, exactly opposite. If you see a rapid increase, normal EtCO2 will be with 35 to 45, and suddenly it keeps increasing like this. When you see a rapid increase in EtCO2, as I told, very important, it is seen in malignant hyperthermia. Again, here itself, we'll discuss few points about malignant hyperthermia, which used to be very important and favorite question for PGI. But in the recent INSET, we didn't see the question on malignant hyperthermia, but on any day, malignant hyperthermia is an important topic. What are the points we know about malignant hyperthermia? Malignant hyperthermia is an autosomal dominant disorder affecting on which receptor, affecting which chromosome 19, which receptor, ranolin receptor. What happens? Increased release of calcium from the sarcoplasmic reticulum. What happens if there is increased release of calcium from sarcoplasmic reticulum? There will be vigorous muscle contractions. When there's a vigorous muscle contractions, what happens? The metabolism increases. When the metabolism increases, there will be tachycardia, initially hypertension, then goes to hypotension, cardiovascular collapse will be there, and the characteristic, the metaspasm may occur, and the increased temperature is seen in the body. Okay, and what are the drug which is most common which triggers malignant hyperthermia? It is succinylcholine. You have to remember that. Okay, and what is the treatment of choice? This is dantrolene sodium. How do you can diagnose? One is by genetically, and there is something called caffeine halogen contracture test or IV halogen contracture test. Okay, this is what you want to remember about malignant hyperthermia. Then coming to rapid decrease in EtCO2. This rapid decrease in EtCO2 is seen in conditions of pulmonary embolism. Rapid decrease in EtCO2 is seen in conditions of pulmonary embolism. Then you see, yesterday when we discussed this, if EtCO2 is around 0 to 10, and if they give waveform, another waveform like this, so suddenly it is 40. So this is an ongoing CPR. This is an ongoing CPR. And suddenly the increase of capnography waveform indicates a return of spontaneous circulation. Usually these two waveforms will be given adjacent so that it will be easier for you to identify. Return of spontaneous circulation. Return of spontaneous circulation, ROSC. ROSC. And another waveform, if the capnogram form wave doesn't touch the baseline, if it doesn't touch the baseline, that indicates CO2 rebreathing. CO2 rebreathing. And what are the changes in when does EtCO2 increase? EtCO2 increase, for you to easily remember, in those conditions where there is increased metabolism in the body due to whatever reason, and in conditions of hypoventilation. No need to by heart. When does it decrease? Whenever there is a decrease in metabolism in the body and related disorders and hyperventilation. If you see this, no need to by heart this. Any increased conditions, any increased metabolism, let it be like fever, sepsis, seizures, malignant hypothermia, thyrotoxicosis, all increases. Decreased metabolism like hypothermia, pulmonary hypoperfusion, cardiac arrest, it decreases. Okay, so this is what I want you to remember about this capnography waveforms. This 12 waveforms, if you can remember this 12 waveforms like nothing like that, and you can't miss a question from the capnography waveform, I want you to remember. So quickly to consolidate, see here, this is a normal inverted square shape, normal controlled ventilation. Inverted U-shaped, it is a normal spontaneous ventilation. Shark fin appearance is a characteristic of bronchospasm. See, this is in the word bronchospasm, characteristic of bronchospasm, which is seen in obstruction of airways like kinking and endotracheal tube obstruction, and in obstructive lung diseases like COPD and asthma. And cardiogenic oscillations is seen in thin children and in those with thin chest wall. And curare cleft or notch indicates the spontaneous breath in a controlled ventilation, where you see in the plateau phase, you see a dip. And if the curare cleft or notch is seen in the middle of the surgery, you administer the muscle relaxant. And if it is after the surgery or end of the surgery, you administer the reversal agent. Then a flatline capnogram is seen in cardiac arrest, esophageal intubation, acute disconnection, or in accidental extubation conditions. Then very important, slow increase in EtCO2 is hypoventilation, slow decrease is hyperventilation. Rapid increase is malignant hyperthermia, rapid decrease is pulmonary embolism. These two waveforms go simultaneously, hand in hand, ongoing CPR, and indicates return of spontaneous circulation. And if the capnograph waveform doesn't touch the baseline, then it is carbon dioxide rebreathing. This is very, very, very important. I will give you 15 seconds to quickly go through these capnography waveforms before we go to the next important topic. I mean, a few guys are repeating, voice is breaking in between. Sincere apologies. I know, like many of you are saying it is fine, and is it still breaking? Am I audible clear? Oh, surprising. Like 80% are saying fine, 80-90%, and like 10-20% is okay, fine. Okay, guys. Then coming to another important thing. So, okay, temperature monitoring, it is like just 2 to 3 points you can remember. The principle of this is thermistor. Core body temperature is measured at what sites? Core body temperature in the body is measured at pulmonary artery, tympanic membrane, nasopharynx, and distal esophagus. And most accurate measure of brain temperature is seen in tympanic, is given at tympanic membrane. And if they ask the question, most accurate measure of core body temperature is at pulmonary artery. And intermediate temperature is best measured at the rectum. So the another most important thing is about the CNS monitoring. In previous days, there used to be EEG monitoring, electroencephalogram, where the light anesthesia is synchronization of alpha and delta waves and theta waves, and deep anesthesia is delta waves. But this is not important for us. The important thing is bispectral index. Very, very, very important. What they had done is this EEG, instead of the 20 leads, 19 leads, they kept like 4 leads here on the forehead. And this 4 leads gives a waveform similar to a EEG waveform. And this, rather than we interpreting it, it is converted into a number. And based on that number, we can see whether the patient is completely awake under anesthesia, whether completely slept, or the adequate anesthesia is being given for him regarding the amnesia component will be all tested. So this is the most common method to monitor to depth of anesthesia. So score of 0 is the patient is, it's a completely silent brain. It is a completely silent brain. And score of 100 is completely awake. And for us, the important is score adequate for anesthesia is 40 to 60. 40 to 60. Now the question comes. In this, you may get a question saying that a 28-year-old female is posted for emergency appendicectomy, and intraoperatively bispectral index score is being monitored, and the bispectral index score read as 76. What will you do? You increase the anesthesia, you decrease the anesthesia, you keep the anesthesia the same. What do you do? Come on, type in the chat box. The patient's score is 76. What do you do? Fantastic. You increase the anesthesia. When you increase the anesthesia, you brought this from 76 to somewhere between 40 to 60, so that the patient will be adequately anesthetized. Similarly, you may get a question. A 38-year-old gentleman had a polytrauma, and he's getting an emergency laparotomy done, and intraoperatively, when bispectral index score is done, and bispectral index score showed 28. What do you do? You decrease the anesthesia. Why do you decrease the anesthesia? Because you are giving more than required. You are wasting the gases, and after that, what happens? After the surgery, the patient takes more time to awake. So that is why bispectral index score is very, very important. A clinical question based on this, if asked, like, you can't afford to miss this. Okay, this is about bispectral index. How you can see there will be 4 leads. Try to identify. Even if you get an image-based question, you can't afford to miss this question. Okay, this is bispectral index. And similarly, if you see this, if there are 3 leads, it is similar to this. It is called as entropy. Just as one image-based question, I want you to remember, guys. Okay, this is one. And then coming to another important thing, just 2 points. The neuromuscular monitoring. Neuromuscular monitoring, it is used to monitor the muscle relaxation, and most commonly used is ADrPlexus. ADrPlexus supplied by ulnar nerve, and most accurate measure is seen in orbicularis oculi. Orbicularis oculi supplied by facial nerve. Okay, and here, like, there are many things like train of 4 and all, which when we discuss about the agent's muscle relaxants per se, we will discuss. Here, there are other quantitative neuromuscular monitoring. If you see, this was a question way back asked in 2017. Please log in about page 103. So nothing. See, 0 means flatline EEG, 100 means completely awake, 40 to 60 is what adequate for anesthesia. If you see this 3 leads, similar to like bispectral index has 4 leads, 3 leads, it is also a way of monitoring. This is called as entropy. That is that. I don't want to remember that one point. That's it. And the question asked in 2017, like anything which has myography, it is a way of monitoring neuromuscular monitoring. Let it be acceleromyography, electromyography, synomyography, mechanomyography, phonomyography. phonomyography. Okay, this is all related to the quantitative neuromuscular monitoring. And there is something called train of 4 ratio. If you get this question, like, see, this is not the time for you to clearly explain. When I take an image-based session in VSV, I'll explain. The train of 4 ratio for complete relaxation is 0 to 0.1. The train of 4 ratio to avoid residual neuromuscular blockade is more than 0.9. That is 0.9 to 1, basically. Like you can remember, 0.9 to 1. And the modality which is used to differentiate phase 1 and phase 2 blocks of succinyl choline is train of 4, which you see the fade phenomenon. You see the fade phenomenon. Just remember this fade phenomenon. As I told, in depolarizing blockers, you won't see you see the consistent but diminished response, and in non-depolarizing blockers, you see this fade phenomenon. Okay. Then, quickly, one important point, and if you get this as an image-based question, I don't want you to miss this. See, this is also a pulse oximeter. This is a reflectance pulse oximeter. Normally, when pulse oximeters, what happens, guys? There will be a photo LED will be on one side and photo detector on the other side. But here, if LED and photo detector on the same side, that is called as reflectance pulse oximeter, used in forehead in pediatrics. This is one image-based question. And see, this is transesophageal echocardiography. You see this transesophageal echocardiography, similar to how you insert in endoscopy, you insert this and you see the heart just like you see from the bottom. So this is used as the most sensitive to detect intraoperative MI by detecting the regional wall motion abnormality, and it is most sensitive to detect air embolism intraoperatively, predominantly used in cardiac and neurosurgeries. Is it lagging? Then, see, what is this? If you get this image-based question, what is this? If you get this image-based question, you should not miss this. What is this? Come on, type in the chat box. Very good. It is a pulmonary artery catheter or Swan-Ganz catheter. Yellow color with 7 leads or like 7 ports or 5 ports, like Swan-Ganz catheter. Please don't miss this, guys. Okay. Then this is all about the monitoring. I'll give you 30 seconds to consolidate before we go to the anesthesia drugs, most important drugs for subspecialties. Your time starts now. Quickly consolidate or you relax. It's up to you. Okay. Now, see, this is not the time actually to read about, to discuss about each and every drug. What is the thiopentone? What is its physical properties? What is its action on CNS, CVS, respiratory system? What is its effects, side effects, on all these things? So now what we are going to do is quickly consolidating based on systems. For cardiac surgeries, what is the IV induction agent of choice? What is the inhalation agent of choice? What is the inhalation agent of choice? What is the muscle relaxant of choice? And what are the any special properties related to that, like similar to cardiac surgeries, neurosurgeries, respiratory surgeries? Then it comes to obstetric surgeries or the patient with renal disorders, hepatic disorders. All these things we are going to discuss about this. So cardiac surgeries, what is IV induction agent of choice? IV induction agent of choice is etomidate because it is the most cardiostable drug. Most cardiostable drug. And second favored drug is propofol. Etomidate followed by propofol. Okay. And you know, thiopentone causes hypotension and tachycardia. And propofol causes hypotension and bradycardia, but slightly less. And ketamine causes hypertension and tachycardia. Then, what is the inhalational agent of choice? It is isoflurane. Inhalation agent of choice, isoflurane, because it causes the least decrease in cardiac output. Then muscle relaxant of choice, it is vecuronium. And what are the drugs contraindicated? Ketamine and halothane are contraindicated. Why? Because they stimulate the sympathetic system and cause increase in heart rate and blood pressure. And remember, atropine should not be used during reversal in ischemic heart disease. Okay. Then, what is the agent of choice in shock patients? In shock patients, the agent of choice is ketamine and pancuronium. Ketamine and pancuronium. Ketamine, because again, the same property is effectively used here, increasing the heart rate and blood pressure. And pancuronium, because of its maximum vagolytic activity, it causes increase in heart rate and blood pressure. Then, yesterday we discussed, if a patient had CAD and stent has been inserted, what is the deferral time for elective surgery? We discussed, if it is a bare metal stent, it is 1 month. Drug-eluting stent, it is 6 months. The elective surgery has to be postponed. And in CABG, we have to postpone for 6 weeks. So if a patient had CAD and CABG surgery is done and elective surgery has to be postponed for 6 weeks, the same person for the stent has been inserted, bare metallic stent, 1 month has to be postponed, and drug-eluting stent 6 months. Okay, then they'll ask a question specifically right to left shunts, like for example, tetralogy of Fallot. In tetralogy of Fallot, our main aim is to increase the afterload. Please remember, this is peculiar. Increase the afterload. Hypertension is preferred intraoperatively. When hypertension is preferred intraoperatively, the IV induction agent of choice is ketamine. IV induction agent of choice is ketamine because it increases the heart rate and blood pressure. The inhalation agent is desflurane. And the muscle relaxant is pancuronium. Pancuronium. At the same time, in left to right shunts, you prefer decreased afterload. Here, hypotension is preferred, exactly opposite, where that IV induction agent of choice is propofol. Inhalation agent is isoflurane. And muscle relaxant vecuronium because it is most cardiac stable. Okay, this is what I want you to remember. This is about cardiac. This is about cardiac. Then coming to neurosurgeries. Neurosurgeries, as I told you, IV induction agent of choice, it is both propofol and thiopentone can be used. Both have cardiac cerebroprotective properties. Propofol or thiopentone. Inhalation agent of choice, isoflurane, preferred than sevoflurane. And muscle relaxant of choice, you prefer vecuronium or atracurium. And what are the drugs contraindicated? Again, ketamine, halothane, and succinylcholine, because they increase in ICP. Succinylcholine. So intraoperatively, what do you do? What are the measures to decrease the ICP? The measures to decrease the ICP. See, I mean, for those who are asking about this PDF workbook and all, this will be uploaded in your app. So don't worry, like you are not going to miss anything. For the trust you had on us, we will make sure you will get each and every point, and you won't be left alone. So it's our responsibility to handhold you and make sure that you are going to touch your dream seat in the corridors. You are going to walk in the corridors of a medical college as a postgraduate. So don't worry, like we will take care of everyone, and every query and every concern will be duly addressed. Leave it on us, guys. Okay. And what are the measures to decrease the ICP? You can hyperventilate. It is about, you can hyperventilate intraoperatively. You can get a question like what are the measures? Hyperventilation, mannitol, by giving mannitol, and by deeply sedating, by deep sedation. Okay. And avoid glucose solutions intraoperatively as they increase cerebral edema. And in head injury, very, very, very important, rule out cervical spine and basal skull fractures before intubation. Very, very, very important. Okay. This is about neuroanesthesia. Just 10 seconds, see to these points. IV induction agent of choice, you can use propofol or thiopentone. Inhalational, you prefer isoflurane or then sevoflurane. Muscle relaxant, you can use VEC or atracurium. Drugs contraindicated are ketamine, halothane, or succinylcholine. And measures to decrease ICP are hyperventilation, mannitol, and deep sedation. And avoid glucose solutions as they increase cerebral edema. In head injury, rule out cervical spine and basal skull fractures before intubation. Then coming to obstetric anesthesia, as much as possible, prefer regional anesthesia. Regional anesthesia is preferred over general anesthesia. And when you are putting, when the patient is planned for LSCS, but usually in regional anesthesia, spinal, 30 to 40% less dose is needed for spinal anesthesia. Suppose a 60 kgs person, a 25 years old, 60 kilos female, normal female, if they need like 2.5 ml, you need 30 to 40% less in pregnant. That is 1.5 to 2 ml, 1.5 to 1.8 ml will be sufficient in a pregnant. Why? The less dose requirement is due to, this was also a question asked in 2017. Less dose requirement is due to exaggerated lumbar lordosis, increased sensitivity to local anesthetics, and increased vascularity and increased sensitivity to local anesthetics. Okay. Then LSCS in general anesthesia. Suppose if at all you are planning for general anesthesia, it's going to be a rapid sequence induction. And because it has increased risk of aspiration, so you have to do the rapid sequence induction. And very, very clearly, no bag mask ventilation, a big no. No bag mask ventilation. What are the contraindications for bag mask ventilation? Pregnancy, hiatus hernia, congenital diaphragmatic hernia, tracheoesophageal fistula, meconium aspiration syndrome. Okay, and full stomach. Then, if at all in pregnancy-induced hypertension, what is the anesthesia of choice? In mild patients, you can go for spinal anesthesia. In moderate, you can go for spinal plus epidural. In severe, when we anticipate seizures, go for general anesthesia. Then coming to labor analgesia. Labor analgesia is a lumbar epidural anesthesia based on patient demand, and drugs used most commonly are bupivacaine or ropivacaine along with fentanyl. Ropivacaine or bupivacaine along plus or minus fentanyl. So bag mask ventilation contraindications you want? Okay, it is full stomach, pregnancy, hiatus hernia, congenital diaphragmatic hernia, intestinal obstruction, tracheoesophageal fistula, meconium aspiration syndrome. But with RSI, in the next session, there will be a quick session for me, like which will be explained about RSI. Don't worry. Then coming to pediatric anesthesia. Pediatric anesthesia is very important. What is the induction agent of choice? Usually, you prefer to go for inhalational. Pediatric induction agent of choice is sevoflurane, and you maintain. For maintenance, you can use anything. You can use either CO, or you can use ISO, or you can use desperate. So, because why you need for induction, you need sevoflurane. Sevoflurane is sweet smelling. Because it is sweet smelling, and rest all are like slightly pungent other than halothane. This sevoflurane is, which is a sweet smelling agent. And muscle relaxant of choice is usually atracurium. And laryngoscope most commonly used is Miller. And very, very, very important, which I also explained in the previous session, the cuffed endotracheal tube can be used. If in the options, if they say all of the following are true except and cuffed endotracheal tube can't be used in children, it is a false statement. It is according to 2020 guidelines, cuffed endotracheal tubes can be used in children. Then Coming to ophthalmic surgeries, peribulbar block is usually preferred over the retrobulbar block. The reason is in peribulbar block, there's no chances of retrobulbar hemorrhage because there's no chances of retrobulbar hemorrhage. No chances of retrobulbar hemorrhage with peribulbar block. With peribulbar block. And what are the drugs contraindicated? Ketamine, succinylcholine, because they increase the IOP. And this is one of the favorite questions in yesterday years, like at least like 4 to 5 years back. We didn't see this question in the recent past, but again, an important thing. Remember one point, oculocardiac reflex, which is seen in squint surgeries or strabismus surgeries. What happens is if the surgeon in the squint surgery, if they manipulate medial rectus, particularly this muscle is what they ask, manipulate medial rectus, sometimes you may see a bradycardia or asystole. Bradycardia or asystole. And how do you treat? Ask the surgeon to immediately leave the muscle. Leave the muscle, medial rectus. And you give atropine. You give atropine. Give atropine. Then coming to orthopedic surgeries, usually majority of the times for orthopedic surgeries, regional anesthesia is preferred, like spinal anesthesia or peripheral blocks like brachial plexus block. And when you are performing a long bone surgery, watchful for fat embolism. And the most vital step is tourniquet deflation, and you have to be very, very, very careful. Tourniquet deflation. Tourniquet deflation. Then coming to laparoscopic surgeries, the ideal gas is argon, but most commonly used is carbon dioxide because of its high diffusibility. Because of its high diffusibility. And the complications in laparoscopic surgeries, what are the complications that can occur? In regard to cardiovascular system, it can decrease the cardiac output. CNS, it increases the ICP. In respiratory system, it may cause VQ mismatch. And basal atelectasis, capnothorax and capnomediastinum. Because capnothorax and capnomediastinum. What do you treat? Like capnothorax and capnomediastinum, it is basically conservative management. And this capnoembolism. See, embolism means there will be rapid decrease in EtCO2, but capno itself is increased carbon dioxide. So what are the characteristics of capnoembolism? If you see this, capnoembolism occurs, usually the EtCO2 will be like, initially there will be increased EtCO2 because of carbon dioxide accumulation. Initially there will be increase in EtCO2. Followed by decreased EtCO2. Where is it? What is written after CO2? High diffusibility. Done? Then coming to respiratory disorders. In respiratory disorders, because of the lung involvement, as much as possible, prefer regional anesthesia. And if you are going for general anesthesia, if at all you are going for general anesthesia, the IV induction agent of choice is usually ketamine or propofol. Ketamine or propofol. Inhalation agent of choice is sevoflurane. See, earlier you used like halothane was used, but because halothane has a lot of side effects, we are not using nowadays. Halothane is also a very good respiratory drug, but again, we are not using halothane because if at all sevoflurane is not there in the options, then go for halothane. But halothane has so many side effects, we are not using this commonly. And muscle relaxant of choice is vecuronium. Muscle relaxant of choice is vecuronium. See, all the drugs which can release histamine like atracurium, mivacurium, and all these things we can't use in respiratory disorders because they may cause bronchospasm. And what are the drugs contraindicated? Thiopentone, because it may cause bronchospasm, and atracurium may cause release of histamine, and also mivacurium. See, there are other drugs also like D-tubercularine and all, but I'm not mentioning this because we are not most commonly using this. At least remember atracurium and mivacurium. Then, those patients with hepatic disorders, the IV induction agent of choice is propofol. The inhalation agent of choice is sevoflurane. because it is a drug with no acyl products. No acyl products. And muscle relaxant of choice, it is ADrCurium or cisatracurium. You know the reason, right? ADrCurium or cisatracurium, because they got degraded by Hoffman's elimination. They got degraded by Hoffman's elimination. No renal or hepatic involvement, so that is safe to use in liver and renal disorders. And what are the drugs contraindicated? Halothane is a big no, because halothane causes something called halothane hepatitis. Halothane hepatitis causing centrilobular necrosis. 75 to 85% mortality. Very notorious drug, which we call halothane. Okay, and other drugs like vecuronium, because this muscle relaxant, vecuronium is eliminated through liver. Metabolism is through the liver. Okay, and then coming to, in all liver disorder patients, coagulopathy has to be ruled out and correct all the coagulation abnormalities. Correct all the coagulation abnormalities. Then coming to renal disorders, the IV induction agent of choice is propofol. The inhalation agent of choice is either you can use isoflurane or desflurane. Muscle relaxant of choice, as we discussed, it is ADrCurium or cisatracurium. And what are the drugs contraindicated? All the muscle relaxant which gets metabolized or eliminated through kidney, we can't use. Like for example, the drugs contraindicated, methoxyflurane, which has high. Methoxyflurane is the most nephrotoxic inhalation agent, which forms high output renal failure, which is vasopressin resistant polyuria. Okay, and pancuronium, because elimination is through kidney. D-tubercularian, again the same thing, and galamine. And in renal disorders, please be careful about the electrolyte abnormalities. Correct the electrolyte abnormalities. Then coming to hematological disorders, nothing but acceptable hemoglobin. These guidelines keep changing, but remember, roughly acceptable hemoglobin level for elective surgery is 8 grams per deciliter. Surgery in critically ill patient is 10 grams per deciliter. And minimum platelet count for an elective surgery is 1 lakh. 1 lakh. Then endocrine disorders, anesthesia of choice in diabetes mellitus patients with diabetic neuropathy, you prefer GA, general anesthesia. General anesthesia is preferred than regional. If there's no diabetic neuropathy, then regional is preferred. Then thyroid patients, you usually optimize the patients to euthyroid levels for elective surgery. And because in hypothyroid patients, usually dose requirement will be less. Dose requirement will be less. Dose requirement will be less. Then neuromuscular disorders, like quickly 2 points in myasthenia gravis, like myasthenia gravis and muscular dystrophies, as much as possible go for regional anesthesia, and opioids and benzodiazepines are avoided in view of respiratory compromise. And IV induction agent of choice is, you can use either propofol or etomidate. Inhalation agent of choice is sevoflurane. Muscle relaxant of choice is ADrCurium. And there will be resistance to succinylcholine in myasthenia gravis. So succinylcholine is very important. It is contraindicated in muscle dystrophies due to presence of extrajunctional receptors. Because of presence of extrajunctional receptors, what happens? It causes exaggerated hyperkalemia. Exaggerated hyperkalemia. Okay, then this is a very important image. Try to remember. This is called as, see, normally the position for intubation, when the patient is lying down here, like normally the patient will be like this, and then they keep the neck like this. I'll explain about this position, Nagel's position, where there will be flexion at cervical spine for 15 to 25 degrees and extension at atlanto-occipital joint for 75 to 85 degrees. But here, this is called as a ramp. Rapid airway management positioner. Rapid airway management positioner. Ramp is rapid airway management positioner. Here, in obesity, regional anesthesia is preferred as much as possible, when compared with the general anesthesia. If at all you are intubating, you go for ramp position for intubation, rapid airway management positioner, because of considering the short neck and big chest. And and then the question may be asked, what are the drugs which are given based on the ideal body weight, and what are the drugs which are given based on the total body weight? The drugs which are given on ideal body weight, usually all IV induction agents are given on the basis of ideal body weight. And muscle relaxants which are given on the basis of ideal body weight are vecuronium and rocuronium. And on the basis of total body weight are succinylcholine, atracurium, and cisatracurium. Succinylcholine, atracurium, and cisatracurium. And opioids which are given on the basis of ideal body weight are remifentanil and total body weight are fentanyl. Opioids on basis of ideal body weight is remifentanil and total body weight is fentanyl. And MAC value doesn't change with the obesity. MAC value doesn't change with the obesity. Okay. Now, quickly, you have 1 minute to quickly go through this and quickly consolidate. And before we go to our next and last topic for tonight, anesthesia for daycare surgeries. Your time starts now. So this is plus or minus fentanyl, Sarthak, and so ideal site to measure temperature, like if they mention just ideal site to measure temperature, then go for pulmonary artery. That means they are asking measuring the core body temperature. If they ask specifically intermediate temperature, then rectum. If they ask brain temperature, tympanic membrane. Oh, sorry. Then coming to the daycare surgeries. Anesthesia for daycare surgeries, the last topic for tonight. Anesthesia for daycare surgeries. What is meant by daycare surgery? The patient gets admitted and get operated and discharged on the very same day. What are the advantages of this? Basically, it is like it is less time consuming. The patient will be having psychosocial and economical benefits. Psychosocial and economical benefits. And they have fast recovery and ambulation. And less chance of nosocomial infections. So, can all the patients be operated? No, for daycare surgeries. There is a certain criteria. What is the inclusion criteria for daycare surgeries? There are ASA 1 and 2 patients. There will be less severe comorbidities. And this is important. There should be a responsible adult at home. Don't ignore this point. Once you discharge the patient to home after daycare surgery, there should be a responsible adult at home. If at all something happens, to bring back responsible adult at home. And duration of surgery less than 90 minutes. And those procedures with less post-operative complications. Similarly, what are the exclusion criteria? It is ASA 3 to ASA 3, 4, 5 automatically will become exclusion criteria. That is severe or life-threatening comorbidities. And no responsible adult at home is an exclusion criteria. Please remember. This looks silly. In examination, now you remember this. In the examination, what happens is responsible adult, how is it related to this? So don't ignore this, please. No responsible adult at home. Morbidly obese patients. And those with extremes of age. Extremes of age, that is like very old age patients, premature infants, and all these things is contraindicated. This is exclusive criteria. Exclusive criteria. Okay. Then, what are the drugs of choice? Intravenous induction agent. See, the daycare means basically they should have a rapid induction and rapid recovery. That means they have to go and act fast, and the recovery also should be faster and less side effects, so that you should not worry about like what happens once the patient gets discharged. The drug of choice, intravenous induction agent, is propofol. Inhalation agent in adults is desflurane. In children, it is sevoflurane. Muscle relaxant, mivacurium. Opioid, remifentanil. Benzodiazepines, you can use remimijolum or midazolam. Remimijolum or midazolam. This is a drug of choice. IV induction agent of choice, propofol. Inhalation agent in adults is desflurane. In children, sevoflurane. Muscle relaxants, mivacurium. Opioids, remifentanil. Benzodiazepines, remimijolum or midazolam. And so I want you to remember two scoring systems. When do you discharge the patient? Like when do you think the patient can be discharged from PACU, that is post anesthesia care unit, to the ward, and from ward to the room, ward to the home? Basically, there are two scoring systems. That is called as, first of all, try to remember the names. The two names are modified Aldrich recovery score. Modified Aldrich score. Okay, and another is something called post anesthesia discharge scoring system. Post anesthesia discharge scoring system, PADS. Post anesthesia discharge scoring system, PADS. Okay, post anesthesia discharge scoring system, PADS. So in this, two things I want you to remember. If you remember this modified Aldrich score and post anesthesia discharge scoring system, you are done with this. If at all you want to remember one extra point, that is, it has both these scores has maximum score of 10. Maximum score of 10. And what is the score required to discharge? It should be more than or equal to 9. Very important. Even if the score is 8, the patient is not fit for that. They won't usually ask you based on like if the patient, based on their activity, respiration, circulation, they won't ask. If at all you want to remember, that's up to you. But like I want you to remember at least two scores: modified Aldrich score, post anesthesia discharge scoring system. Both are things are used for the scoring systems used in the recovery for the decide on the decision from PACU to ward or then and to the home. And the score, maximum score is 9, and the score at least required is more than or equal to 9. There are various components measured. How is their activation, activity, respiration, circulation, consciousness, oxygenation, and here they measured about the vital signs, activity level, nausea, vomiting, pain, and surgical bleeding and all. But for you, no need, don't think much about this. At least remember Aldrich score, post anesthesia discharge scoring system, maximum score is 10, more than or equal to 9 is what you should target for. This is about daycare service. 30 seconds for you to consolidate. Mainly the advantages, inclusion criteria, exclusion criteria, and the drugs used. Give me a second. Okay, guys. So that's all about tonight. And in the next session, we'll keep you informed, and make sure you attend these 6 a.m. and 9 p.m. sessions where you'll be getting the maximum input. 1 second, just let me